Hello friends. Today we are going to start a lecture series of on chest X-ray. In this series we will discuss basic X-ray and advanced X-ray, normal X-ray and pathological X-ray. This is big lecture, so I'll divide into many videos. So let's see our first video. In that we will discuss basic technical aspects. How to take X-ray, which position we are supposed to take X-ray. So let's see. So first of all, we should know who discovered X-ray. So X-ray was discovered in 1895 by a scientist Röntgen, Wilhelms Röntgen. And this was great discovery and he got Nobel Prize after 6 years of his discovery. And since then, after almost 130 years after also, X-ray is so commonly used that it is not replaced by anything. Though there are advanced investigations are there like X-ray, CT, I mean CT scan, MRI, but still X-ray is used widely. If you talk about chest X-ray, it is mainstay of chest imaging. So whenever patient come to you, you ask chest X-ray, and chest X-ray contains around 30 to 40% of all X-ray. If in any center 100 X-rays are being done, out of 100, 30 to 40 X-ray will be chest X-ray. So common. Why? Because it is fast. Within 10 minutes or 15 minutes, we can get X-ray plate or X-ray film. Low cost and low radiation exposure as compared to other diagnostic method like CT scan. So this is widely used. So now let's discuss about technique and projection. How to take X-ray, all these things. So in X-ray means room, there are two things. One is X-ray tube by which radiation is coming out. Radiation means it's like a rays, light rays. So radiation rays are coming out from X-ray tube. Another thing is X-ray film. This is like a plate. So X-ray is coming out from X-ray tube and it's hitting on X-ray film by penetrating body. And in this example, the man is standing like that. Plate is in anterior side, touching the chest. X-ray is coming from back side. So this is posterior anterior view, and this is most commonly used X-ray in field of pulmonary medicine. And the distance between X-ray tube and X-ray film is around 6 meter, because 6 meter the ideal distance at which we will get most accurate X-ray. If distance is more than 6 meter, the organs will look small. If distance is less than 6 meter, then organs will look large, pseudomegaly, like pseudocardiomegaly. So it is distance of 6 meter. Now, if we discuss about what view we should take. So as I told you, posterior anterior view is the most taken view or most useful view in field of pulmonary medicine. In this, X-ray is coming from back side. See, this is X-ray tube. X-ray is coming from back side, hitting posterior part, traveled throughout the body and coming from anterior side and fall on X-ray film. So X-ray means rays travel from posterior to anterior. That's why it is called posterior anterior view. X-ray are coming from posterior side. The structure which is situated at posterior side will looks anteriorly in X-ray film. This is X-ray film. So whatever we see first, it is posterior organs. And at the posterior side of X-ray, we will look for anterior organs. So what is there in posterior is vertebral column. So we can see vertebral column anteriorly, and posteriorly what we can see, this is heart. So in real scenario, heart is anterior organ. It is anterior organ. Posterior is vertebral column. But when we are taking chest X-ray PA view, posterior to anterior, the posterior will come first. We can see vertebral column anterior side and heart in posterior side. So benefit of PA view is that we can move scapula out of the field. Whenever patient is standing to take X-ray, then patient is standing like this. So this shoulder is going out. When shoulder is going out, it is pulling scapula outward. So our lung field is empty. So whenever there is opacity in the lung field, we can see clearly without scapular shadow in chest X-ray. So this is benefit for PA view. Then heart will reduce magnification in PA view. If you take AP view, then heart will come anteriorly and there will be pseudocardiomegaly, means heart will look bigger in AP view. But in PA view, it is reduced in size, means it's normal size. So whatever size of heart is there, we can see in PA view. Another advantage is that reduced radiation dose to the anterior radiosensitive organs. So what is the radiosensitive organs anterior side? This is heart, aorta. So these are radiosensitive organ. When we are taking PA view, posterior anterior view, so rays coming first posterior side, then anterior side. So whatever organ is there in anterior side will get less radiation as compared to posterior side. So this is benefit of PA view, that our heart and aorta anterior structure is getting less radiation exposure as compared to posterior side. Another is respiration is more effective when standing. The ideal X-ray is when it taken in deep inspiratory phase. Ask patient to take deep inspiration and ask patient to hold it in inspiratory phase. So when patient is standing, then only he can do inspiratory phase. If patient is lying down, he cannot hold inspiratory phase for long time. So this is benefit of PA view. Another view is AP view, anterior-posterior view. This is less preferred view in field of pulmonary medicine. It is being done when patient is not able to go to radiology department. So mainly bedside X-ray. Okay, so whenever patient is in ICU or ward or patient has trauma, who cannot walk or who cannot stand, so bedside X-ray is being done and it is mostly anterior-posterior view. So you can see this is X-ray tube, radiation is coming like from anterior and plate is being kept on posterior. So this is AP view. So when it is done, this is done in when patient is not able to walk to radiology department and he cannot stand. The problem is that heart and mediastinal looks wider. That is called pseudocardiomegaly. So AP view is less preferred, is being done bedside condition when patient is not able to stand or not able to walk. So X-ray is 2D structure. If you remember 2D, 3D means we can see all three dimensions, means anterior, posterior and lateral. But chest X-ray POV is 2D dimension. If we want to see 3D structure, then we have to get lateral X-ray. How to take lateral X-ray? Plate is on one lateral side and X-ray tube is another lateral side. So radiation is that passing from one lateral side to another lateral side. So what we can see is lateral X-ray. This is lateral X-ray. So we can see this is ribs. This is anterior. And this is vertebral column. This is posterior. So we can see lateral X-ray and we can found where is the lesion. This is anterior side, middle side, or posterior side. Okay. So there are a lot of advantage of taking lateral X-ray. First advantage is whenever there is opacity behind the heart, we cannot found in APVO or PAVO, but we can find in lateral X-ray. So this is heart. I told you now it's anterior structure. So you can see heart in anterior. See, this is anterior. If there is opacity here behind the heart, we can find in lateral X-ray. Then substernal, this is sternum. So if there is opacity behind the sternum, we can find in lateral X-ray. Then any opacity in mediastinum. Here is mediastinum. So any opacity in mediastinum difficult to find in PA view. We can easily find in lateral X-ray. Another advantage is whenever there is minimal pleural effusion, it is difficult to find out in PA view. Then we can get lateral X-ray done. In lateral X-ray, this angle is CP angle, costophrenic angle. So whenever there is little fluid, we can find arbitration of this angle, CP angle. Is large fluids, no problem. PA view is good, but minimal effusion, lateral X-ray is good. So these are the advantages of lateral X-ray. Then another view is decubitus view. This is not commonly being done nowadays because of ultrasound and CT scan, but previous day it was very useful. So it is still useful nowadays when there is no facility for CT scan or ultrasound, mean periphery. So what is doing in this one? Asking patient to lie down in their lateral side. Okay, the concept is to diagnose minimal pleural effusion by X-ray. So whenever you asking patient to lie down on one lateral side, the dependent part, if there is effusion, will get down by gravity. See, this is effusion. So if there is effusion on left side, the left side should be downwards and right side should be upward. If there is effusion on right side, then right side should be downward, left side should be above side. So this is decubitus view. So it is useful to diagnose minimal pleural effusion because pleural effusion is settling down because of gravity. So now let's see basic radiography. So whenever you get X-ray in your hand, you have to see three things in beginning. Name of patient, that the X-ray you are holding in your hand is belong to same patient whom you are going to interpret, because radiology is busy department and many times it happens then somebody's X-ray is being hand over to some other patient. So whenever you are getting X-ray, you check name. Name is written on upside or lower side. Okay. Then you check date, date of X-ray. Because in field of pulmonary medicine, serial X-rays are having their importance. So we have to look for date. If it is not written, you have to write by your white markers on the X-ray. Another thing is you have to mark which is left side, which is right side. Usually written on X-ray, this is right side and opposite left side. If it is not written, you have to identify which is right, which is left. So how to identify? This is aortic knuckle. It is there in left side. So this is left side. Another thing is heart shadow. This is left ventricle. This is on left side. Okay. Another thing is this black shadow. What is this? This is fundus shadow. Fundus means stomach. Air in stomach is looks like a black. So whenever there is fundus shadow, that is side left. Exceptions are there, but usually aortic knuckle, heart shadow, and this fundus shadow, they are there in left side. So by this we can determine side. Now, whenever you are holding X-ray, you have to check quality, whether this X-ray is good or not. If you interpreted bad X-ray, then you will end up with wrong diagnosis. So three things you have to check. You have to check rotation, you have to check whether film is inspiratory or expiratory, and you have to check penetration or exposure. The mnemonic is RIP. RIP looks so bad, so I add up PE also. So RIPE. Rotation, inspiratory or expiratory, or penetration or exposure. So three things we have to see to interpret X-ray. Rotation. What is rotation? When patient is standing in front of X-ray film, me see this is X-ray. Patient have to stand like that, X-ray film touching both side equally. If patient is rotated like this this one or this one, this one or this one, so this is rotated film. So how to check whether rotation is there or not? The in between of vertebral column, there is spinous process. Can you see this yellow one? This is spinous process, and this is clavicle. So medial end of clavicle and the distance of this spinous process, that is called spinoclavicular distance. It should be equal both sides. See, for example, this is spinous process, and this is medial end of clavicle. This is, so we have to see spinoclavicular distance. This is more on left side and less on right side. So this is rotated film. So like that, we have to check rotation. So what is the disadvantage of rotation? So in this X-ray, if you can see, this is spinous process, and you can see this is clavicle. So you can see the right clavicle is going far away from spinous process. Means right side is away. Means patient is standing like that. So my right clavicle is going far away from spinous process. This is right side rotation. So what is the disadvantage? So we cannot see clearly cardiac, vascular, or mediastinal structure. In this X-ray, you can see this is heart shadow. Can you see this is heart shadow? So this is pseudocardiomegaly, or heart is rotated. So we cannot say this is normal or abnormal unless we should see whether rotation is there or not. You can see this is mediastinum. So if there is rotated film, you should not interpret it and you have to repeat. Then only you can give correct diagnosis. See this X-ray. In this X-ray also, you can see this is spinous process, and this is right clavicle. This is left clavicle. So you can see this the distance is more. Right side distance is more. Here, this is also right rotated film. Means patient is standing like that. Right rotation. So this X-ray should not be interpreted, and we have to repeat X-ray. Now another thing is whether film is inspiratory or expiratory. As I told you in beginning, that we have to get inspiratory film for correct diagnosis. Ask patient to take deep inspiration and hold, then click X-ray. Okay. So how to see whether inspiratory film or expiratory film is there? We have to count anterior ribs. I told you in PA view or posterior anterior view, first rib is posterior rib. So first rib is posterior, means this is posterior rib. But we have to count anterior ribs. So anterior rib is which is seeing behind. This is 1, 2, 3, 4, 5, 6. So whenever there is less than 5 ribs anteriorly, it's expiratory film. See, this we can count 1, 2, 3, 4. After 4, anti-rib is not visible. So this film is expiratory film, this is inspiratory film. So we have to give inspiratory. It clear? I hope it is clear. Now important exposure. Exposure means just radiation dose. How much radiation patient is getting. Patient has to get adequate exposure. If it is underexposed or overexposed, both things should not be there. Okay, because adequate exposure is required to visualize structure which we are looking for. How to check whether overexposed or underexposed? We have to see spine. It should be visible up to T4. So this is vertebral column. So 1, 2, 3, 4. So if it is visible up to T4, beyond that we cannot see clearly. It means this film is good exposure. If it is seeing beyond T4, it means it is overexposed. If we are not able to see even T4 vertebrae, then this is underexposed. See, this is. So this film is underexposed. How? Because we cannot see vertebral column clearly behind the this behind the structure. So this is underexposed film. What is the disadvantage? Spine not visible. We know. Left hemidiaphragm may not be visible. Prominent marking may appear more prominent because this is underexposed film. Means there is less black, more whitish. If we are seeing more whitish, we can wrongly diagnose as ILD or increased vascular marking. So this is underexposed film. In contrast, this is overexposed film. We have given lot of radiation, so it it gives more black areas. This is overpenetrated. So if span are visible more than T4, you can see this is vertebral column. So we can see clearly. So this is overexposed film. What is the disadvantage? Lungs marking may be absent or decreased. See, we can see black only. So we can interpret it as pneumothorax or emphysema if we doesn't know the concept of penetration or exposure. Because this is black, looks like a pneumothorax, but it is actually not pneumothorax. It is overexposed film. So we should get correct film, unless we will otherwise we will diagnose wrongly. Now we have checked all quality. We have checked the name of patient, age of patient, date of x-ray, which is right, which is left, quality of x-ray, rip, rotation, inspiratory or expiratory, then penetration or exposure. We have checked all. Now we have to see which structure gives black area, which structure give white area in x-ray. So black means radiolucent, means the x-ray is penetrating easily, or the structure which is absorbing radiation more will looks black or radiolucent. The structure which is not penetrating x-ray, it looks radio opaque. Okay, so body tissues, air or air filled structure penetrated x-ray produce dark or black areas, that is radiolucent. So this is black, so air is black. Can you see this? Air is black. Outside environment black, air is black. The structure which is not penetrated by X-ray gives black or radio opaque. Means white color. See, this is bone, white color. This is liquid. There's heart. There's liquid in heart. This is white color. See, this is white color. See, this is bone, scapula. So this is concept of radiolucent or radio opaque. Okay. So if you see normal structure in X-ray, we can see the white or that white or black. So air is black. This is air. Okay, this is air. You can see air in trachea inside the trachea. This blackish tissue. Okay, fat. Fat will looks like a grayish white. Means it is white but slightly blackish, grayish white. Water will looks white. This is white. Blood is water, so it is looks a white. Okay, bone will look say white, more white than water. See, this is bone, this is bone, this is bone, more whiter than liquid, है ना? And more than bone, the calcium deposits, prosthesis and contrast media will be more whiter, and whitest thing is metal. I'll show you in other x-ray. So in x-ray, the most black area is air and most white area is metal. Before metal, x-ray contrast. Have you seen that barium cell or barium meal, how much white it is looks like? So this is white testing. Bone, calcium, and this is blacker, soft tissue, fat or blackest is air. So this is the gradient from black to white area. Okay, so if you see this x-ray, you can see this is water, whitish area. This is air, black area, bone, more whiter, and this is metal wire. Can you see this metal wire is how much white it is? So denser the thing, more white is the thing. Okay, this is pacemaker made up of metal. So it looks like more white. So this is how we are taking good X-ray. If there is good X-ray, we have to interpret it. If it is not good X-ray, we should repeat X-ray. So in this lecture, I think this is enough. In another lecture, we will see the normal X-ray and normal structures in X-ray. What are the things we can see in normal X-ray and how to read a normal X-ray, which is useful in your exam. So see you next class. Till then, thank you very much. If you really like this video, please share with your friends, like it, and if you have not subscribed to the channel, please subscribe it. See you in next lecture. Thank you very much.